One of the things I love about GI is not a single week has gone by since I was in fellowship that I didn't look at something and go, that's different.
Dr. Brent Lacey, how you doing, my friend?
Hey, Ryan, it's good to see you again, man.
Nice to see you as well, hanging out with 1,000 of our friends around the world. Let me stop this user from spamming everyone. Christopher, take your junk links and get out of here. I'm excited to chat with you about GI today, because who doesn't like talking about poop, which is probably one of the biggest misconceptions about what GI is, right?
Yeah, I mean, we talk about vomit too. So, I mean, there's all kinds of great stuff that we get to hit.
Yeah.
But, you know, it's funny because I tried very, very hard not to become a gastroenterologist, actually. So, you know, when I was in med school, I was like, okay, well, I don't know what I want to do. Maybe internal medicine, maybe surgery. And then I ended up loving internal medicine. And then I thought, okay, well, I just won't do GI because that's, you know, awful. But GI medicine was absolutely fascinating. It was one of my favorite things that I learned in med school. And then when I actually got to do my rotation, I was like, wait a second, we talk about poop a lot, but I don't see very much of it. I don't see nearly as much as even the nurses do. So I think I could do this.
Yeah, that's always one of the things when I talk to GI docs. They're like, you don't deal with poop a lot. You talk about poop a lot, but you don't deal with poop a lot. So that's good. Big misconception out there. So let's talk about the bread and butter of GI. What does that look like for you?
Well, actually, that is one of my favorite things about GI is that there really isn't a bread and butter per se. It's really diverse and interesting that way. So if you look at all the different internal medicine subspecialties, GI is by far the most diverse. Before we went to ICD-10, back when we were still using ICD-9 codes, GI had more ICD-9 codes than any other specialty, including infectious disease, which I always found very impressive. But you think about it, we have 7 different organs that we deal with. I mean, pulmonologists get 1, cardiologists get 1, you know, and I've got 7. And they all get sick in a variety of interesting and weird ways, and sometimes get sick simultaneously in weird and interesting ways. So, you know, I guess you'd say the more simple garden variety stuff that we see is going to be things like acid reflux, irritable bowel syndrome, hemorrhoids, dysphagia, so trouble swallowing from, you know, reflux-induced strictures, things like that. That's going to be, I guess, what you'd consider bread and butter. But one of the things I love about GI is not a single week has gone by since I was in fellowship that I didn't look at something and go, that's different.
That's great. What is your favorite procedure in the GI world?
My favorite procedure, I think my favorite procedure actually is endoscopic dilation. That's definitely the one. And I think that's my favorite because it's the one that provides the most immediate relief for patients. So somebody comes in and they've been choking on their food for, you know, 3 years because they've got a stricture forming in their esophagus. And then I can go in and just stretch it out and dilate it. And then they call me up 2 weeks later and they say, I ate a steak for the first time and it was amazing. Thank you for that. That's probably my favorite.
That's pretty awesome. So it's interesting. I don't know what I have. I've never been worked up, and we don't need to turn this into Diagnosed Dr. Grade A. But ever since, and I was telling you before, and I've talked about it on a YouTube video about my demyelinating lesions in my spinal cord. Right around the first set of symptoms that I had in my face, which is where I get most of my symptoms from, the lesions in my spinal cord, which is weird anatomy. Is I had a moment. I was sitting. I remember it to this day. I was actually on a mission in the Air Force, and we were on our way back home, and we stopped in San Diego for something. And I was sitting. We had stayed the night at a hotel, sitting in a Subway eating breakfast, and my throat just clamped down on me, and I didn't know what was going on. I'm like, I can't breathe right now. I thought I couldn't breathe. I thought I just went paralyzed with being able to breathe. And I slowly realized that no, it was my esophagus that had spasmed, but I was still able to breathe and work through it. The freakiest thing in the world, scared the crap out of me, and now it happens like once every couple months or more often, depending on on what I'm eating, and I have to be careful if I eat too much or I eat too fast. Like my throat is like, no, I don't want that. And I think it's part of my demyelinating stuff. It seems to be all around the same time, but it's just super interesting. So when you talk about that, right, when you talk about dilating someone for strictures and the relief they get, like that hits me, because I know as soon as my esophagus relaxes, I'm like, oh God, I can breathe again. I can continue eating my food, which I love.
Yeah, well, it's surprisingly common, actually. I mean, so when I was in the military, I would see my primary population was 19 to 21-year-old guys. You know how that goes. And one of the more common conditions that we see that causes dysphagia, and for the pre-med students, that's difficulty swallowing, where food gets stuck in the middle of your esophagus. One of the more common things that we see cause that is something called eosinophilic esophagitis. And I saw that incessantly in the military. I was doing probably 20 to 25 dilations a month on these guys. It was amazing. And, now that I'm in private practice, my population's a lot older, of course. And so I don't see so much of that. I see a lot more acid reflux induced strictures and esophageal cancers and things like that. But it's amazing how common it is. It's not something you'll ever see reported on TV. It's not something that, people would think to Google, because nobody even knows the word for it. So, but I see it all the time.
Is that age related, or is there something in the military, some sort of exposure, occupational exposure from the military?
Yeah, I think it is mostly a demographics thing. So, because I do see it some in, I've seen it in every place that I've ever lived, and it seems to be largely centered in people under 30 is where we make the primary diagnosis. So I'd say the peak age of diagnosis is probably in the neighborhood of 22, 23, something like that. I do occasionally see people older than that, but I think it's just a demographics thing. Cause, especially when I was at Camp Lejeune, I had a couple hundred people over the age of 60, and then I had 75,000 19-year-old Marines. So, it's just the demographics of where you're at.
That's pretty crazy. So talk about the path to become a GI doc. That's a very common question we get is what does the training path look like? Obviously 4 years of medical school. What does the rest look like?
Yeah. So it's 4 years of college, 4 years of med school. And then during your third year of med school, or your fourth year of med school, we tend to focus on the internal medicine subspecialties, just as you're preparing for internal medicine residency, which is next. So then you do your 3 years of internal medicine residency. And so for the pre-meds out there that don't know what residency is, maybe that's sort of an extended apprenticeship type thing. And then after your residency, you do 3 years of GI fellowship. And so fellowship is to GI as residency is to internal medicine. So it's a 3-year extended apprenticeship where you learn all of the medicine of GI, all of the procedures of GI. And then you have the option after your 3-year fellowship to actually do a sub-fellowship in one of a few disciplines like inflammatory bowel disease and liver transplant, and motility and things like that. Most people will I'd say most people will just stop at the end of GI fellowship. So that's 14 years after high school if you go straight through.
Yeah, long time. So it's interesting. You're one of the few former military docs that we've had on here. Now in private practice, one of the very common questions we get a lot from pre-meds and medical students who are potentially thinking about the military is what does that look like military medicine wise versus what is practiced out in the community. Now you've seen both sides. What are the biggest differences you think in terms of how the medicine is practiced?
Well, I think we covered it a little bit actually already. I think the primary difference is really the difference of the demographic. And so when I was in the military, for example, I'm seeing mostly young men and women. And so we tend to see a lot more diseases of the young. So I saw a lot more eosinophilic esophagitis. I saw a lot more Crohn's disease and ulcerative colitis. And so now that I'm seeing a more diverse age range of population, I tend to see a lot more diseases of aging. So we see more acid reflux induced problems. I see a lot more cancers, obviously. We see a lot more issues like cirrhosis of the liver. So chronic severe liver damage from things like hepatitis C and alcohol. So we tend to see a lot more of those kinds of things. So I think it's really a question of the demographics is the primary difference. But other than that, the medicine that we practice in the military is basically the same medicine that I practice in private practice. It's just what slice of the population pie are you actually seeing?
Yeah, very interesting. So talk about the poop for a minute. A question that came across earlier. Does healthy poop float or sink? That is the question we have to answer today.
Yeah, so it's a great question, and so the answer is both. It has to. So the reason that your poop floats is one of two potentials. It has to do with the contents of the stool. So the more air that you have in the stool, the more likely it is to float, and the more fat that you have in the stool, the more likely it is to float. So it's mostly diet related. And honestly, it varies pretty widely. So whether it floats or sinks is actually less important. The other question that's a corollary to this that I see that I also get a lot is, what color is poop supposed to be? Is it bad if it's green? If it's bad if it's yellow, or things like that? And basically, what I tend to tell people is if your poop is forest colored, so brown, green, yellow, that's fine. If it's forest fire colored, red, black, white, that's not so good.
I like that. Forest fire. Call Smokey the Bear. That's awesome. Yeah, my son, who's 2, he was having some massive green poops. We're like, what's going on here? He's Googled it. Just normal parents, like, why is my kid's poop? They're like, green poop comes from blueberries. If you eat a lot of blueberries, I'm like, oh, the kid demolishes blueberries like no tomorrow. So yeah, we definitely know if he gets blueberries, he has green poops, which is pretty funny. So you talked about kind of the training path to be a GI doc. For you, when you left the military, why did you go out into private practice versus going and finding an academic job somewhere?
Yeah, that's a great question. Well, so a couple of reasons. One is that I got a crazy great job offer, and so part of it was just that the offer was phenomenal, and it was close to home, so that was kind of an easy one. But I really hadn't been looking at academic jobs, honestly. For me, I hate research with white hot intensity. So I would rather do almost anything than research. So and basically every academic job requires you to do some research. I mean, if you're thinking about doing academic medicine out there, and you interview at a place and they say, oh yeah, we want all kinds of different people, so you don't really have to do much research. They are lying to you. They will make you do it. Okay. So for me, that was the big factor. I just didn't want to do any research.
How did you, so a lot of fellowship, a lot of residency is less, but fellowship potentially is very research heavy in terms of being competitive to match into fellowship. Is that the same with GI?
Well, so military is a little bit different, of course. So it's a point-based system. So you get points for deployments and points for earning your rank faster and things like that. So it's a little bit different, but yeah, research is very helpful for competition and in GI fellowship. I will say it's been interesting. I think over the last probably about 10 to 15 years, we've seen a sharp increase in the competitiveness of the GI fellowships. It's pretty impressive. And so a lot of, it's true. I mean, GI docs make a good living. We do. So, I mean, not in the military, so, but it's definitely, it's definitely become more competitive. And so, yes, research can definitely help you along those lines. What I will tell you in my experience, though, what I have found is that the most helpful thing is connections, is knowing people. So if you think you want to do GI fellowship, then going and doing a GI rotation while you're in med school, or doing a GI rotation while you're in residency, would be super helpful, or utilizing some of your network connections. So if your internal medicine residency director knows a GI fellowship director somewhere, see if you can get a 2-week rotation out there, just as like an audition rotation, because there is absolutely no substitute for just being present with people. Because if I'm a GI program director, and I'm thinking, who do I want? I got two people whose resumes look really similar, but I got one guy that I saw for 2 weeks and I thought he was really great, or one gal that I thought was just, a superstar. I'm going to go with the known quantity. So there's just no substitute for that.
Networking. You got to get out of your comfort zone and get out there and meet people. So important. But social distance, wear a mask. Talk about the topics, right? Somebody comes to you, goes to the doctor, an internal medicine doc, family practice doc, a pediatrician. A lot of those conversations typically, conversations can go any which way, but typically are just very normal. Visit, checkup, kind of, I'm doing fine, just checking in. When I go see a GI doc, it's like, hey doc, my butt hurts. Hey doc, my poop is weird. Hey doc, I'm vomiting all the time. Like, they're not the most comfortable conversations. How do you make patients comfortable? How do you deal with the uneasiness of those conversations?
One of the things that I found is, I think the most helpful about it is to simply talk about it very frankly. And not try to beat around the bush. I use the term stool that's our primary euphemism for fecal material, if you will. So we use the word stool. And I think as I just start talking about it with folks, just the idea that we're talking about it starts to feel more normal, starts to feel very natural. And I will tell you that as a general concept, by the time that people are coming in to see me, they're pretty motivated to talk about it because they're having pain, they're having diarrhea, they're having constipation, and so they want to talk about it, and they want to get an answer. So I don't tend to have too much of a problem teasing that kind of thing out of people. But I think just by being very candid with people and saying, okay, my understanding from your primary care doc is that you've been battling some diarrhea for the last few weeks. That sounds really miserable. Why don't you tell me about that? What's going on? And just giving them that opening and just stating it out loud and then just letting them roll. And by that point, people are pretty motivated to just talk about it.
Yeah. Kayla asks, how often do you see intussusception? But GI docs wouldn't necessarily cover that, right? That's more gen surge.
So the general surgeons typically will be the ones that get called for it, but I do see it occasionally where a patient has intermittent intussusception. So for those of you out there who don't know, intussusception is where if you have the bowel going like this, what happens is I'll tell you what, if it's going like this, if it's going towards the screen like so, then what'll happen is the colon will basically telescope, or the intestine will sort of telescope back in on itself. So imagine like you have a pair of socks and you roll them up into a ball, and that's more or less what intussusception is, and it tends to cause an intestinal obstruction. And so we see it more commonly in children, but and of course the surgeons will see it. Where I tend to see it is folks will come in with intermittent abdominal pain and they're developing intussusception, and it turns out that there's some kind of an anchor point around which the colon is wrapping. And so that's usually going to be a cancer or some kind of a tumor, either benign or malignant, but that's going to be the most common scenario. And I definitely have seen that even in folks who are, fairly young and healthy otherwise.
Yeah. I was in medical school. I got to be first assist. I think it was Christmas Eve. I was on a pediatric surgery rotation. We had a 13-year-old come in with intussusception around, I forget the exact thing, but it was something left over from her umbilical cord. And she had an intussusception. So I got to be first assist in the surgery. So that was pretty fun. I'll always remember those things. Where did that question go? Lots of people asking, like, what do you do for this? What do you do for that? Everyone wants their medical question answers. Oh, fecal transplants. Let's talk about fecal transplants.
Yeah, I've seen a dozen or so questions about that. Yeah,
a hot topic these days. I've asked my GI buddies about fecal transplants. Seems like fecal transplants are the cure for everything nowadays. But still super limited in terms of what it's actually good for treatment wise. So what is a fecal transplant, and why the heck would anyone think about that?
I love this topic. Actually, stool transplants are one of the single most effective treatments that we have in GI in terms of effectiveness rates, but the current studied efficacy is somewhat limited. So stool transplant or fecal microbiota transplant, or FMT, is the terms that you'll typically see. And so it's done one of a few ways, but the most common way that we see it is that, is that someone will come in, we'll basically do a colonoscopy for them. So they'll do the bowel prep the night before, clean themselves completely out, try to empty as much of the bad bacteria and old stool as possible. We go in, we do a colonoscopy, and then we have collected. And what we used to do, this is amazing. So what we used to, we've come a long way in this field. So, but what we used to do is we would, prep someone a few days ahead of time. We would get usually a family member to literally donate some stool. I mean, straight up, we'd get them to go poop in a bucket, and then, we take it off to the lab, have it tested for hepatitis C and HIV and, all the different infectious diseases and such. And then, I am not making this up, we'd go to Walmart, we'd buy a blender, and we'd, blend up the stool with some sterile water or some saline. And then we would have that stool smoothie, if you will, and go do the colonoscopy and basically just infuse all that stool directly into the colon. It's a little more sophisticated.
A literal poop shoot.
It is exactly what it was. So it's a little more sophisticated now. There's a couple of laboratories that will collect donated stool and test it and freeze it, and then they ship it around the country. So we use a lab in Connecticut, for example, that'll have stool samples. They'll send people, they'll overnight it in FedEx or whatever, and then we just let it thaw and then infuse it through the colonoscopy, and it works pretty well.
What about poop pills? Those are a thing too, right?
Yeah, that would be the next evolution of FMT. There's a lot of work going into that. The challenge with that is getting it to actually populate the colon, because the most common reason that we do stool transplants right now is for Clostridium difficile infections, or I guess it's Clostridioides now. But C. diff, as it's commonly referred to, is a really nasty colon infection. And so when we get to a point where it's become refractory to medical therapy, stool transplant's typically the option. Well, it's confined to the colon, and so if you use the stool pills and they release in the small intestine, they may get chewed up before they ever make it to the colon. So that's the challenge, is getting the delivery mechanism right.
Vedika says, I will never look at green smoothies the same again.
Yeah, unfortunately, pretty much all of my stool analogies are food related, which is unfortunate. So I'll try not to ruin any more foods for anybody.
Nice. That's awesome. So the procedures, talk about the kind of the fun stuff that you get to play with procedure wise as a GI doc.
Yeah, that was one of the things that attracted me to gastroenterology in the first place, was that I love working with my hands. I do a lot of crafts like woodworking and things like that. And I've just kind of always been really into making stuff with my hands. And so I really enjoy procedures. But our primary procedures are going to be endoscopic. And so basically you have a long flexible camera inside of a tube, and going along that same channel, you'll have an open channel through which you can pass tools. You have a channel for a light source. You have a channel for suction, and then you put the patients to sleep. You insert this camera into one of a couple of orifices, and then just go looking around. And so, when I'm explaining it to patients, I liken it to CSI or NCIS. If you ever see those, detective shows where they snake the fiber optic camera under the door and start looking around, it's not fiber optic; it's an actual video camera. But that's the basic idea. And so we're just basically working our way around. And if we find something that we need to address, either to stretch it out with a balloon and dilate it, or take a biopsy, or use a snare to actually remove something, then then we can do that all at the same time. But that's the majority of our procedures are going to be endoscopically based, and that has been a really remarkable evolution over the last 15 years to see some of the different things that we can do now. So endoscopic ultrasound, for example, has evolved mightily in that case. So for example, in someone who has really bad acute pancreatitis, so they have bad inflammation of the pancreas, and they develop a massive cyst afterwards, that's just this huge thing, we can actually go in with an endoscopic ultrasound device and basically basically all inside the stomach, poke a hole through the stomach directly into that cyst, and then insert a catheter that will drain the cyst directly into the stomach, and then the person never has to go to surgery. I mean,
Wow.
it's crazy the stuff that we can do now. It's amazing.
Wow. Brittany says, I've been waiting for him to mention hemorrhoids. He must got a funny take on those grapes.
Yeah. You know, hemorrhoids are either really not a big deal or they're tremendously awful, and there's kind of nothing in between. And I see hemorrhoids an awful lot. So when people think about people think about hemorrhoids, they typically are thinking about external hemorrhoids, which are outside of the anus, and you'll have pain and itching, and it hurts to sit down, and preparation H. That's all of the external hemorrhoids. But then when people start thinking about bleeding, but it's painless, that's typically going to be more internal hemorrhoids. And I see hemorrhoids in just about every patient that I scope for colonoscopy. We just see them all the time. They are just absolutely.
Do you think
incessant.
they've gotten worse with the smartphones, because we all sit there on our phone going, I'm browsing the internet for hours?
Oh yeah, so Dr. Google is really terrible for this kind of thing. By the way, if you're
not Dr. Google, but hemorrhoids getting worse because we're all sitting on the pot longer because of the devices.
Oh, that's possible. So it's interesting. So I see my worst hemorrhoids that I see are in my pilots and my truck drivers. Those are the ones that are the worst because like you said, it's the same problem. They spend all their time on there, and anybody who's got chronic constipation definitely see problems with that. What's interesting to me, as we were kind of going back to the stool question earlier, you just reminded me of something. So one thing that I get sometimes, actually quite a lot, is people will. I don't know if they think I'm gonna not trust their description of the stool, but they'll be talking about, it's like, I've been having all this diarrhea. Hang on a second, I've got some pictures to show you. I was like, no. I went into GI because I don't like seeing poop. I will talk to you about it, but no, I will not see your pictures. Like, no, you got to see this, doc. I was like, I really don't. I trust you to tell me the truth.
That's awesome. No pictures. All right. I want to bring a few students on and do some cases with you. We'll talk through some cases. No pictures today, but we'll talk through some cases with some students. If you want to come on, raise your hand.
All righty. So I'll give you. So this is a case that I like to use to. At least I've got more people coming on, so this will be good. We can get
just the two.
A few different questions. Yeah. So this is a case that I like to bring up by way of highlighting how important it is in GI to take a really careful, detailed, nuanced history. So as I kind of set this case up, and I'll give you the basic information and then let you ask me some questions about it, and we'll kind of tease out what's going on with this case, because it was really, really interesting. One of the things that's very important to recognize about GI is you cannot shotgun your way into the answer by just ordering a whole bunch of tests. You can get away with that in certain subspecialties. So cardiology, everybody that comes in with chest pain is going to get an EKG, a stress test, cardiac enzymes, and plus or minus a echo, plus or minus a cardiac catheterization. So you can shotgun your way into the answer a lot of times. You really can't get away with that when it comes to GI. So it's all about what the patient is telling you. It's all about their story. So with that in mind, so this gal that I saw, I was a first-year fellow. So I'd been on my GI training for about, 3, 4, or 5 months at this point. And so I had a gal that's coming in. She was 37 years old. She had been having diarrhea every day for about 4 years or so. And she had originally started out as just once or twice a day, and it was always loose, never formed, never really had any blood to speak of, maybe the occasional bit on the toilet paper, but very, very minor. And then the diarrhea had gradually progressed over the last 6 to 8 months to the point that by the time she was seeing me, it was, 8 or 10 times a day. I mean, so if you can imagine that, about once an hour having to run off to the bathroom to have a really watery, urgent stool. and she's a mom of 3 or a mom of 4, and so she's neglected to come in and get seen because she's trying to take care of her kids. And so finally she's just coming in, she's like, it's too much, I gotta deal with this. So she's sitting there. So what kinds of questions, if I'm the patient, what kinds of questions might you think to ask me to try to figure out what's going on?
Well, I know there's such thing as like a stress-related diarrhea. So maybe like if she's stressed for taking care of her kids, that could be like the reason for chronic diarrhea.
I love it. Okay, so yes, you're probably thinking of irritable bowel syndrome. That is by far the most common thing that I see. And so that is going to be high on the list in a young woman who's got significant diarrhea, and stress definitely plays a role there. So 100%. So yeah, so she's got a lot of stress for sure. Okay. What else?
Would she ask, can you hear me?
Yep, we hear you fine.
Oh, okay. Would she ask like about her diet to see a dietitian as well?
Yeah, absolutely. So there's a variety of things that can cause you to have chronic diarrhea diet wise. So one of the more insidious ones that people don't think about is sugarless gum. So sugarless gum contains xylitol, which is a non-absorbable sugar. And so it's an osmotically active thing. It's the equivalent of drinking Miralax, basically. So I've definitely seen diarrhea from people that are chewing gum like there's no tomorrow. So that's great. No major dietary things that she reports, though.
If you guys want, for all of you, I don't know, Brent, if you've seen this, if you go onto Amazon and you search for sugar-free gummy bears, and you go to the Albanese 5-pound sugar-free gummy bears and read the reviews, they are hilarious about all the diarrhea that is caused by sugar-free gummy bears.
There you go. That's the reason why.
So funny.
All right. What else would you guys want to know?
Maybe if any of her activities during the day have anything to do, like if she's sitting for long.
Yeah, sure. Okay. So, and to that, sort of as an extension of that, has she maybe been exposed to something during one of her activities that could be, say, an infectious cause, like she's been traveling, or she spends a lot of time in a prison ministry or something like that, but nothing like that.
What else, Daniel? Got anything else?
Like maybe if she has a family history of GI issues.
Ooh, I like that a lot. Yeah, because that starts to bring up things like Crohn's disease and ulcerative colitis. Yeah, you betcha. That's a great one. But no family history of anything that she reports.
Maybe any other medications she's currently on?
Yeah, absolutely. Oh, that's a big one. Okay, so that's one of the number one things that we got to do is scrub the list. And so things like metformin for diabetes and a medication called olmesartan, which we use a lot for high blood pressure. And gabapentin, which we'll use for nerve pain. I mean, all those things are very common causes of diarrhea. But there's nothing on her list that really screams medication-induced diarrhea.
And also, how long has this been going on? Like, is this recent, infrequent?
So it's mainly escalated over the last 6 to 8 months. So it's fairly recent. It's chronic, but it's fairly new.
And is there any change in her activity in the last 6 months that she is has she moved somewhere or something?
Oh yeah, great thought. So no, she's always been in the same area, but it has limited her activities because she can't go anywhere because she has to have bowel movements all the time.
Maybe if she's tried a different food and she might be allergic to that food and she doesn't know that she's allergic to it.
Oh yeah. So you're thinking like maybe lactose intolerance and things like that. You bet. But no major change in her diet. And she's even tried, try and going dairy free and tried, getting off of certain foods and just really no success.
So nothing she's noticed has made it feel even slightly better or worse?
Really not, unfortunately. Yeah, it's just been fairly consistent, fairly steady. So these are all really, really good questions. These are great questions. So I think that's a really good set of questions to start with. So now that we're kind of getting the sense of, all right, we've got a 37-year-old woman. She's had gradually progressive escalating diarrhea that is not improving. It's consistent, but we're not finding any specific provocating factors. There's no exposure history. There's no medications that we can find. So we still have a pretty broad differential here. So now it's time to start thinking about what kind of testing might we want to do in order to try to make a diagnosis here.
I just want to make one comment. Kate in the comments I think future emergency medicine physician, because Kate's already given up. She says she's a lost cause. Kate's like, I ain't got time to diagnose this. Like,
yeah, that's an anesthesiologist right there. It's like, can I intubate it? Then I don't care.
Should we start with X-rays?
Okay, a reasonable thought. One thing that's challenging for us in GI, plain X-rays are not really helpful except in the setting of maybe a perforation where you're looking for free air or an obstructive process. But maybe a CT scan we might think about. I usually don't go straight to that for just plain diarrhea. But if I had a 45-year-old telling me they're having new abdominal pain, yeah, you betcha. I got to be thinking about weird stuff like, ovarian cancer or lymphoma or other kinds of weird stuff. So probably not jumping straight to radiology, but it's a reasonable second tier sort of thing.
Maybe we can then take a sample of her diarrhea and then test it for things.
Fabulous. I love it. Okay, so we're testing for infections. Great. So we mentioned the C. diff earlier. This is a classic sort of presentation that makes you at least worry about the possibility of C. diff. Some parasitic infections, some worm, helminthic infections can do this. So yes, that's a very reasonable thing to check as a next step. Okay, I love it. Daniel, how about you, man? What else do you think?
So just to mention, just to add a little bit of more education in for the students. So typical stool test, right? We call it an O&P, ova and parasite test.
Yeah, absolutely.
A colonoscopy, maybe. Order that.
My man, that's excellent. Yeah, so definitely. And the main thing that I want to rule out for her in a colonoscopy is going to be Crohn's disease or ulcerative colitis. I'm thinking less likely ulcerative colitis in her just because she's not reporting a lot of blood. But Crohn's disease in a 37-year-old with chronic diarrhea, you bet that's way up on the list. Okay, so great. So we've got a great basic plan for going forward. Okay, but I'm going to give you one more piece of history that we didn't tease out yet that is going to become very, very important. Okay, so there's another item on the differential diagnosis that I was thinking about at this time, and that is celiac disease. And I don't know if you guys are familiar with that, but if anybody has ever been to a restaurant or the grocery store and seen gluten-free stuff. Okay, so that stuff exists because of something called celiac disease. So celiac disease is where the intestines become hyperinflamed, and specifically the duodenum becomes hyperinflamed when it's exposed to gluten, which is a protein found in wheat. So it's in wheat flour, which is to say that it's in everything. So what happens is that the small intestine becomes very flat, and the absorption ability goes down dramatically. And so the intestine is not able to absorb as much as it should. And so you get a lot more runoff, if you will. And so you get a lot more fluid that makes it out of the small intestine. And so that's another one that's on my differential diagnosis. And so I'm thinking, well, I'll check her for that. That's an antibody test that I can do in the blood, easy to test for. But so anyway, so I ended up testing her for that. I tested her for the stool. All the stool studies for infections came back negative. Her celiac antibody came back positive. And I was like, okay, all right, I got a diagnosis. And this is why I wanted to bring this up, because here's the twist, okay? When I saw the celiac positive, something she had told me really triggered a memory that bothered me, is that she had been gaining weight. And so I see Sarah in the chat saying after 4 years of diarrhea, had she lost a ton of weight? No, actually, she was really frustrated because she'd actually gained like 30 pounds over the last few years. And that makes no sense if this is all celiac disease, because like I said, celiac disease causes diarrhea by malabsorption. And so if she's having enough diarrhea from the celiac disease that she's having 8 or 10 stools a day, she should be malabsorbing like crazy. She should be vitamin deficient. She should be mineral deficient. She should be losing weight just left and right. And she's not. That was really bothersome. It's like, that doesn't make sense. And so this is why I use this case to highlight the importance of taking a really careful, detailed, nuanced history, because maybe you find one thing, but you miss a second thing. So she has celiac disease. I know that based on the antibody test, but there's got to be something else going on because the celiac can't explain the weight gain. So then I start doing some research. I'm looking it up, and then I find there's an entity called microscopic colitis, which is where you have this inflammation just diffusely throughout the colon at a microscopic level. And so if I look at it with my scope, I can't see it. But if I take biopsies, I could see it. And as I'm researching this, I realize, oh man, there's a really significant correlation between celiac disease and microscopic colitis. And I think, great, I got my answer. She's got celiac. That's going to trigger the antibodies. And she's got microscopic colitis, and that explains the diarrhea and why she didn't gain any weight. I'm home free. Good. So I was planning on an endoscopy so I could do biopsies of the duodenum and make sure that she doesn't have, or that she does have the celiac disease like I thought. And I called her and I said, hey, listen, let me do a colonoscopy too. And let me do some biopsies and make sure you don't have. And she said, great, no problem. So we go in, we do the endoscopy, and sure enough, it looks classic for celiac disease. Classic. And so we take some biopsies and then pull the scope out, and I spin her around and get her ready to do the colonoscopy. And I get 6 inches into the rectum, and I ran into a 4-centimeter rectal cancer, which was not even high on my list at all. And that was actually the thing that was causing the increase in the diarrhea over the last 6 to 8 months. Oh my gosh, you could have floored me with a feather. It was really terrifying to see that. So she definitely had celiac disease, and yet she definitely also had rectal cancer, and the two are completely unrelated. So I use this case to highlight why it is so important to take a really careful, detailed, nuanced history. And this is the thing that makes GI so much fun, at least for me, is that nothing about it is cookbook. There's nothing about it that's, a cookie cutter approach to it. It's everything is individualized. Everything is unique. And so, we got her into the surgeons, and she had stage 3A colon cancer. And if I hadn't teased out that one little piece of data and hadn't thought to do a little bit more investigation, what for sure would have happened is she would have gone another 6 months, and we would have been treating her for a celiac, putting on a gluten-free diet. She wouldn't be getting better. We'd be getting frustrated, thinking she's not being adherent to a gluten-free diet. Eventually someone would come up with the idea, well, let's scope her. And at that point, the cancer would have spread to her liver. It would have been too late. So it was really important to be able to tease that out. So she had two really big things that are completely unrelated that happened simultaneously. Fortunately she is doing great. I was able to keep taking care of her for the next few years till she and her husband moved out to a new city. But man, she did great with that. I mean, as soon as we got the cancer out, within 2 days, her diarrhea ceased. It was amazing. It was absolutely amazing. But she's doing really well. So, but it's stuff like that makes GI so much fun. I mean, I see goofy stuff like that all the time. I've pulled worms out of people's colons. I've seen people that got food impactions with like a chili bean that got stuck in their esophagus. I've pulled dentures out of people's stomachs. That was kind of amazing. A guy managed to swallow the top portion of his dentures, like with the full bridge. I still don't know how he choked that down, but had to go down and find that. I mean, just all kinds of fun stuff we get to do.
Wow. That's a good one. Looks like people like that kind of in-depth thought process. Thanks, Olivia. Thanks, Daniel.
Good job, guys.
Thank you.
All right, let's just do some regular old Q&A. If you want to come on and ask a question, we'll just do some regular old Q&A to wrap up here the last few minutes. Looks like we have Shane back, who's our fan favorite of the group. She's here every week. Hello, Shane. You were missed last week.
Family dinner, man. Had to happen sometime.
Yeah, it's not acceptable. You are not dedicated to this cause. And
hey, I watched the replay. That's right. At least I did that. So are we doing? Can I ask a question?
Just some Q&A.
Beautiful. So you mentioned earlier that GI is an internal medicine specialty. Mm-hmm. But you've also mentioned like several procedures. So I'm kind of curious, like, where do you fall in the balance of doing like a lot of medical-based procedures or medical-based interventions compared to procedurally based interventions?
Interventions, I would say the majority of my interventions are medical. But I would say it's probably split 50-50 in terms of diagnostics between procedures and medical stuff. So like we were talking about with the diarrhea, I diagnose a lot of people with Crohn's disease based on their colonoscopies, but I diagnose a lot of people with infections based on their stool studies. But mostly I see a lot of medical interventions.
Cool. And then I also had a question. You mentioned earlier that you enjoy this a lot because, you know, especially your favorite procedure was, you know, this endoscopic dilation that provides immediate relief. How often do you get to like the point where you can like cure somebody versus dealing with a chronic condition like IBD or IBS?
So it's a good question. I would say, well, so the term, so I want to be careful not to use the term cure, because I don't get to cure a whole heck of a lot of things. Most of the stuff that we do is about chronic management. So infections I can fix and cure. But as you mentioned, inflammatory bowel disease, we use the term remission, just like we would use for cancer. And we get the vast majority of people into remission, but it's not technically a cure. Irritable bowel syndrome, I actually have a lot of success at treating irritable bowel syndrome, but I'm awesome at it. So, but you know, that's the stress-induced diarrhea that, I mean, I'm very much oversimplifying that, but that we mentioned earlier. And, you know, it comes down to, honestly, for me, for that kind of thing, a lot of it comes down to education. So one of my spiritual gifts is teaching, and I really consider myself a teacher and an educator, first and foremost for my patients. And so I spend a tremendous amount of time during my patient encounters coaching and educating and teaching and showing them how to fix things. So I can put someone on Prilosec for their reflux, but coaching them through the lifestyle modifications is at least as important. And so actually we get a lot of success with that kind of thing.
Cool. Awesome. Thanks so much.
Yeah.
Thanks, Shane. Christine.
So what is the coolest case you've ever gotten to experience? And then what is the most difficult or like your least favorite part of your job / cases?
It's a good question. The coolest case that I've ever gotten to be a part of, God, there's so many that would vie for that title. I had a pretty weird case one time. This was about 5 years ago. I was moonlighting, and I had a guy that was bleeding profusely. I mean, just bleeding. He was exsanguinating. And it was a guy with cirrhosis. He had variceal bleeding. And so esophageal varices, for those of you who don't know, are blood vessels that live in the esophagus that are super high pressure in folks with cirrhosis. And when they bleed crazy. And so this guy came in literally bleeding to death. And we did an endoscopic, I did an endoscopic procedure and was able to get little tiny tourniquet on the vessel that was bleeding. But I mean, he was just gushing blood out of his mouth and his nose. It was impossible to see. And we saved his life, and it was an amazing, amazing feeling. That's probably one of the coolest ones, but I've got lots of ones that I think would vie for that title, but that's definitely one of the top 5, I would say. And then what was the second question you asked? Like, what was the weirdest thing, or what was the other question?
What's like the thing you dislike the most about what you do? Okay,
so I'm gonna give you a not so straight answer to that. Okay. And this, but I hope this will answer the question. I am very deliberate about not having that be part of my life. And this is actually a very important thing, I think. So for everybody out there, as you're thinking about medical school, as you're thinking about what specialty you want to go into, one of the things that I always coach my students on is that it's very important to recognize what I call the dark underbelly of the specialty that you're thinking about. You need, in order to be happy in the profession that you're choosing, you need to love almost everything about it and not hate anything. And those aren't the same thing. And it's really important not to do that. So I'll give you the answer that most people would give in my position. Most gastroenterologists are going to say that the thing they like the least is treating irritable bowel syndrome, because it's frustrating. The patients tend to be very demanding. Our therapies are limited. A lot of times we are not successful. It's time consuming, and it's unsatisfying because you don't have any structural damage that you can point to as being the problem. And if you choose to hate that, it will consume your life. it will absolutely kill your joy for your specialty. It's half of what I see. And every specialty has this. So for, for OBGYN, it's interstitial cystitis. For cardiology, it's atypical chest pain. For anesthesiology, it's every awake patient. And so you have to have something, you have to have the ability to learn to enjoy things, even if they are hard to enjoy. If you don't do that, you will end up hating your life. You will end up making your family miserable because you'll have no joy left to bring home to them. And you'll end up hurting patients because you'll get frustrated with them. You won't want to do a good job. You won't take a careful history. You'll roll your eyes every time a new IBS person comes in, and then you won't take that careful history. You'll miss that rectal cancer in that 37-year-old gal. So, I hope that's an answer to your question. I recognize that it's not exactly the straight answer you were asking for.
No, that was perfect. Thank you.
Great answer. Great answer. Love the hate on anesthesia too.
I gotta throw something in there.
Slide in there.
Well, I was gonna say, and he's gonna call me a scope jockey in a second, so that's okay.
That's good. I had something profound to say, but I forgot. So we'll go to Taylor. Hello, Taylor.
Hi. I have a couple quick questions. So
yeah.
Juice cleanses, the hot new trend. How do you feel about that?
It's absolute voodoo nonsense.
Okay.
So my favorite example of this was when I was a fellow. I rotated I did a month of rotation at Cedars-Sinai in Los Angeles, and it was it's in Beverly Hills, like it's on Beverly Boulevard.
The juice cleanse mecca.
Yeah, it was phenomenal. So I was staying in a Motel 6. It was ghetto fabulous, and driving from there to Cedars-Sinai every day, I would pass. I can't remember the name of it. It was like Colon Spa or Intestinal Boutique or something to that effect. And literally, you go in, and you could buy the cleanse with whatever you wanted, lavender and jasmine and eucalyptus and all this nonsense. And like people would charge like $300 for this. And I was like, I need to get in on that racket. But it's absolute voodoo nonsense.
Okay. And then my next question is, so I did some shadowing actually at a GI at Wilford Hall Air Force Hospital for a week. I absolutely loved it. But I know there, the guys that I shadowed split their time pretty evenly between like procedural and clinical. So how do you feel like in the civilian world, did that change, Air Force, civilian, like how do you split your time?
Yeah, so it's a good question. So it's about 50-50, I think, everywhere I've ever worked. So both Navy and civilian. And I went to medical school in San Antonio. I actually rotated at Wilford Hall myself.
No way.
Yeah. So yeah, it's about it's somewhere between 40 to 60% on medical, on clinical versus procedural. And I think as your practice, at least in private practice, as your practice gets more established, you tend to get heavier on the procedures because you do more screening exams. But especially when you're early on, if you take away all the screening exams, I think it's probably right at 50-50, clinical versus procedural.
Okay, cool. That's good to know. Thank you.
You bet.
Thank you, Taylor. All right. Last but not least, Jomana.
Yep. Hello. Can you hear me?
Hello. Yep.
So I had like two questions. They're kind of related, but was there like some other specialty that you wanted to get into before GI, or did you just decide to? Like, how did you know you liked it?
Yeah, great question. So I started off with my second year of medical school. So your first year of medical school is about how the body works. Your second year of medical school is about how the body breaks. And so when I did my pathophysiology course in second year, the medicine that I loved most was infectious disease, hematology, and GI. I found the diseases fascinating for those three, at least intellectually. So when I was in my second year of residency and I had the opportunity to start doing some actual electives, some clinical electives, and getting to see those docs firsthand and the patients firsthand, I did all three of those. And I loved hematology, and I thought oncology was incredibly boring, at least for me. It is a wonderful specialty, and I thought I wasn't going to like it because it was going to be sad. But actually, they have a tremendous success rate. So all the sadness that you see is in the hospital. But as an outpatient, they see success upon success upon success. It's just amazing. But man, oncology was freaking dull for me. I mean, it was just every time you make a diagnosis, it's stage 3 this, so we're going to do this many rounds of chemo, this many rounds of radiation, and this surgery, and it's just very, cut and dried. And I didn't find that particularly interesting, at least for me. But I still love looking at blood smears. I could look at blood smears all day. I love me some hematology. So that took heme out of it for me. And then I came this close to doing infectious disease. Actually, I loved ID. It is absolutely fascinating. It's so interesting. But I think the thing that really swayed it for me, honestly, was, well, two things. One is that, with ID, you really don't get to do any procedures. And I felt like I needed that to be part of my practice, to be able to deliver some actual therapeutics. That was the first thing. And then the second thing, this one kind of surprised me, is the people that are in the specialty. So one of the things that you'll recognize is when you do your various specialties, what you'll find is that the type of medicine, the type of patients that are part of a particular specialty tend to attract people of like traits. And so as an aggregate, the specialty tends to take on a unified personality. And so when we talk about like stereotypes of the various specialties, they are largely borne out, I think, in most people. So, ortho and surgery are very rough and tumble. Let's get in there. Let's, they're very confident. They're very skilled. They tend to be, especially ortho tend to be just bigger folks because you're doing a lot of heavy lifting and things like that. Psychiatry, you tend to be more, cerebral, more, people focused, really great listeners. And so for me, the thing I loved about GI, one of the things was I just loved all the people that I was working with. It was amazing. And I love the ID docs too, but they're just a little too nerdy for me. And so, and I'm a huge nerd. There's no shame in that. But for me, I just really loved every GI person I ever worked with. So I think those are the big things for me there. So, okay, and you said you had a second question, right?
Yeah, you kind of answered it. Like, it was like, so if someone wants to get into GI, what would be like the one thing that you would be able to do, like the quality?
In terms of like how to get into GI, what would be the one thing that gets you into GI, or what's the one thing that?
Like, so when you're looking at like something that, actually, I don't know how to word my question, but it's okay. But thank you so much, doctor.
So already.
You're welcome.
Thanks, Germana. Well, awesome. Dr. Brent Lacey, you have that fancy mic flag, the scope of practice. Talk about your podcast in case some of these fancy premeds want to get a head start on their private practice and financial career.
Yeah, sure. I'd be happy to. So, so a number of years ago, I had observed that the people that are coming out of med school are incredibly well trained to be physicians and really terrible at personal finance and at business. And you got to know that stuff basically right as soon as you get out, is how to lead a team and how to manage your practice and how to bill and code. And, what do I do with this new attending paycheck that I've got? And we're just not taught that stuff in med school. And so I started the scope of practice to basically give people the knowledge and resources they need to be able to manage their businesses more successfully and master their personal finances. So I've got a podcast and a blog and lots of great resources. If you guys want to check it out, it's at thescopeofpractice.com. So, and so you can check out the podcast there. And Ryan, we got to get you on at some point, man. I just realized I haven't had you on yet.
I wasn't going to force myself in, but looking at your list,
I'm officially extending an invitation, man. This is ridiculous. I am delinquent and I apologize. But definitely come check it out. Thescopeofpractice.com, and love to have you.
Do it. Awesome. Well, I'm glad it looks like everyone enjoyed your talk today. They say Dr. Gray always coming through with the quality docs. What can I say? I got tons of awesome people in my Rolodex. So Dr. Brent Lacey, glad to call you a friend and have you on speed dial so I can reach out and Talk about poop anytime.
Hey, you know what? Always game. Vomit too. Don't forget.
Vomit too. We don't care about vomits. Just poop. Just poop. Oh man, awesome. Well, thank you so much for your time tonight, and I'm glad you're well in the great state of Texas. And we will talk soon.
My pleasure. Have a good one.
Have a great night, everyone.